Many women have gone through breast surgery wondering, can I ever feel whole again? Will I be able to see myself in the mirror again? Is there any hope?
I've been practicing in Bangalore for last 7 years.
Yes.
I rarely see a woman coming forward asking for breast reconstruction.
Right.
Why in India is this lagging? What is the reason you think it could be?
Absolutely. I think, because I've worked in UK and now
Right.
when I'm seeing, in India, there is a lot of disparity in terms of reconstruction that is offered to the patients.
Right.
Overall, everybody, we know that breast cancer has increased, with crazy
Yes,
numbers across the world, and
yes.
it's increasing and it will increase in future to a
Yes.
large extent.
But for the general knowledge, what are the types of surgeries we are doing for breast cancer?
So, in terms of breast cancer per se, so initially they used to be quite radical in terms
Yes.
of taking out the whole breast
Entire,
tissue,
yes,
sometimes the chest
yes.
wall muscles, even
Right.
ribs.
Right.
But now, in fact, there is lumpectomies, or you can have only mastectomies.
When should a woman opt for a breast reconstruction? Is it at the time of cancer removal? Is it later or much later? Do one need to wait?
Okay.
So what do you think?
So it can be either time. So it could be at the same time of a cancer surgery, or you can opt to have later on as well.
How costly is this reconstruction?
I think first of all I would like to highlight it's just not a cosmetic thing. It can have
Correct.
both physical and psychological effects on that lady.
I always tell my patient, I cannot do anything about the insurance.
Yeah.
They can reject for any silly reason.
Yes.
Hello friends, welcome to my podcast channel Nothing But Truth. Today I'm extremely happy to have a very dear friend of mine, Dr.Rachana Tataria. She's an MCH plastic and reconstructive surgeon who has spent a good 7 years in the UK. Let's hear from her how she became a plastic surgeon and what are the other trainings she has undergone. Hi Rachana, welcome to my show.
Thank you, Pinky, for inviting me, first of all. And I'm really glad I'm getting to see, my colleagues and friends back from Bangalore. So, I was, as Pinky mentioned, I was with her when we were training in Bangalore Medical College.
Right.
And that's how our journey started in plastic surgery. And then afterwards, I went back to my hometown to Mumbai. For a year I was there. And then I went to get some more experience and fellowships in UK. And that's how,
So what did you do in UK? People would like to know.
So I went for multiple number of fellowship programs.
Right.
And ultimately, because I was really interested to breast reconstruction. So I did a breast oncoplastic fellowship, which is a RCS accredited fellowship, and then a microsurgery fellowship as well, which means that I am dealing with all kinds of breast cancer disorders and how to reconstruct them as well at the same time. So it gives me a comprehensive care around that speciality over there, which was my calling, I would say. I really loved doing that. And then last 2 years I was in Manchester doing a consultant job.
Nice.
And it's good to come back home.
I'm not wrong if I say you're a highly skilled surgeon when it comes to reconstruction, right?
Hope so.
Yeah, it's nice.
Obviously, I have learned a lot of skills there, but I want to, get those skills back into, to India, where I'm working in Mumbai at the moment, and get more people to get advantage of those skills.
Nice. So, as you can see, we are extremely lucky to have such a trained, highly qualified doctor with us today. So, we are going to clarify a lot of doubts regarding breast reconstruction. I think which is a very neglected topic, especially in India. Don't you think, Rachana? We are
Absolutely. I think, because I've worked in UK and now when I'm seeing, in India, there is a lot of disparity in terms of reconstruction that is offered to the patients.
right.
Overall, everybody, we know that breast cancer has increased, with crazy numbers across the world, and it's increasing and it will increase in future to a large extent. And what in UK was special, I found, is, there was 100% rate of offering some form of reconstruction to every lady who was diagnosed with breast cancer, which, is something I would say we need to achieve in India at some point of time. So my idea is to, get, basically offer all the breast cancer patient some amount of reconstructor so as to they have that feel that get their own body shape back again.
Yes,
And overall in terms of confidence, your social life, how your clothing, for example, very at that level as well, you can get back to normalcy with that.
No, truly, Rachana, I agree to it. Even I feel breast reconstruction, especially,
Yes.
it's not about cosmetic.
Absolutely.
Right? Now people think, oh, okay, she had breast cancer. What is the need for reconstruction? So I would like to, highlight
Yeah,
here more
yeah.
is it's not about the
No, that's
cosmetic part.
very well said
Yes.
point.
A
Pinky.
woman,
Yeah.
a breast is a very vital part.
Yes.
It's not about the cosmesis of it.
Absolutely.
I feel a woman doesn't feel a woman.
Absolutely.
Once the breasts have been removed.
Exactly.
So why are we making this woman relive the
Absolutely.
trauma of a cancer?
Exactly.
So once we remove breast for a
Yes.
cancer, and we are not reconstructing, she's living every day, reliving it.
Yeah, yeah.
The absence of
Absolutely.
breast.
Every time you look yourself into the mirror, you remind
Yes,
yourself, of the
exactly.
scar, of the deformities are there. I know some women were not even happy to look at themselves
Yes,
after having
they
the
stop
surgery.
looking at themselves. Yes,
And it impacts your confidence to a great level after,
Yes.
afterwards when you're going back to your work with your kids, your
So
social
breast
life.
reconstruction is not, we are not doing for somebody else.
Absolutely.
It's for that particular woman
Exactly.
who's undergone that
Yes.
she's already a survivor.
Yes.
She has survived the breast cancer.
Absolutely.
Then why not give her
Absolutely.
wholesome?
Yes. I
Right?
completely agree. So, and I think in fact the incidence has gone up in younger age group, which means they have so
Yes.
many additional lives to
Right,
year for.
right.
And that I
Right.
think that quality of life is so extremely important.
Now, what do you feel? So, me, both you, in my practice also, I've been practicing in Bangalore for last 7 years as well.
Yes.
I rarely see a woman coming forward asking for breast reconstruction.
Right.
Recently, I did a surgery, but why do you think, like in UK, say you said it's 100%.
Yes.
Why in India is this lagging? What is the reason you think it could be?
I think there could be multiple factors. One is obviously, I would say, starting from patient awareness.
Right.
Do they really know? Is there an option or not, first of
Yes.
all? And if they have an option, I'm getting to know about the financial aspects of it. So I know
Yes.
some patients, are paying for themselves, some have insurance. So it is a lot of logistical things go around it in terms, if they can afford the surgery or not, if the insurance covers or not. And first of all, and then obviously the patient, I would say the mental status of that patient and how ready that she is to go ahead with that kind of surgery at the same time. And it's good to also know that this kind of surgeries cannot just be done at the same time of your cancer operations, but if you want to take a break and then come back again once you finish your complete treatment and you feel you're in a better state of mind, you can definitely do it
Yes.
afterwards as well once you're finished.
So, as you are highlighting, one, patient themselves not aware.
Yes.
Right? Second, a major fact I feel as doctors.
Yes.
We are not making them aware.
Exactly. That point is very important because your first portal of contact, which doctor you're seeing, what kind of
How aware
care.
they are. Yes.
Is it like a specialty breast clinic or is it like a just a general surgeon
Who's doing it,
exactly.
right,
It depends on the expertise of the doctor.
Correct.
It's quite individualistic what they can offer you as well.
Correct.
So it's important to consider, do some amount of background
Yes.
literature check on that to make sure you're seeing the right person, when
yes.
and you're at least getting the option of doing those procedures.
Yes.
What you have in mind.
Yes.
Obviously, it's entirely up to you to decide, if you want to go ahead or not, and it also depends on your own body as well, makeup.
So what do you say? Another thing even I have noticed is apart from this, the world around them,
Yes.
the family, the relatives, the friends, so and so, they make it, they make it feel like, why is it needed?
Absolutely.
Why do you want to go into it?
Yes.
They make you feel like it's
Yes.
something you're
Yes, the
doing.
social structure.
Yes.
Yes.
It becomes like a stigma.
Yes.
People don't want to talk about it. Why?
So so definitely there's a vast difference in the social structure. I completely agree, in the UK and India. But I think we are definitely catching up.
Yes.
Women are getting more, individual oriented. They know what they want. They are more self-confident. They are working, most of us are, having a job.
Correct.
So I think it's some, it will go up at some point as more and more people become aware of it.
True. Now, from a general awareness for a question is like, what are the kinds of surgery, onco surgeon? Obviously, as a plastic surgeon, we don't try to do the removal of cancer part,
Yes,
right?
yes.
There's a clear demarcation.
Yes.
So when it comes to breast cancer, there are two types of surgeon need to be involved minimum. One is a breast onco surgeon,
Yeah.
right?
Yeah.
Who's going to resect the cancer part.
Right.
Following that, or immediately or later, a plastic surgeon who's well versed with all kinds of breast reconstruction needed. So we need at least two
Yes.
surgeons here.
Yes. Yes.
But for the general knowledge, what are the types of surgeries we are doing for breast cancer?
Okay, so in terms of breast cancer per se,
Right.
if you were, it's evolved to a great extent.
Right.
So it's becoming more and more conservative now. So initially they used to be quite radical in terms
Yes.
of taking out the whole breast
Entire-
tissue,
yes,
sometimes the chest
yes.
wall muscles, even
Right.
ribs, which was too
It's a
too
radical. They were
exactly.
too radical. Right.
But now, in fact, there is lumpectomies, or you can have only mastectomies, which
Right.
is essentially saving your all the structures,
Right.
just the breast itself, and they're always combined with some lymph node surgery into your armpit,
Yes.
which could be either just a simple biopsy,
Correct.
or in cases of some slightly advanced cancers, they might end up removing all of your lymph nodes into the armpit.
So basically, so I understand surgery was you're trying to tell me. One is the surgery involving the breast.
Yes.
One is the surgery involving the lymph nodes.
Yes.
Now, as I don't know how many people are aware, lymph nodes are something which is draining each area.
Yes. Yes.
So obviously, if it is draining a cancer breast, it is going to drain the cancer cell.
Yes.
Hence, for a better clearance, we remove
Yes.
the lymph nodes.
Yes.
Now, in breast surgery, what I understand and what we have been doing as a MS general surgeon, I have done a lot of mastectomy.
Yes.
So, to give a summary, it's like something called breast conservation surgery or mastectomies. Now, when I say breast conservation, it is conserving most of the breast except for the tumor part.
But there's a catch to it.
Right.
So, if you were to have a lumpectomy or a breast conservation
Right.
surgery, which is essentially you take the tumor out with a
Right.
bit of normal margins. And generally, it is always supplemented with radiotherapy
Right.
to give you that, similar
Yes.
survival rates as compared to having a mastectomy. But if, it depends on your breast size and the shape, how it is. So if I were to remove in a, like a 4 centimeter tumor, for example, in a small breast,
Yes.
it will make your breast shape quite awkward. You will definitely have some kind of deformity.
Yes.
Versus removing it simply into a bigger breast.
Yes.
But we do have some techniques in plastic surgery which will help us, shape up that breast better.
Exactly.
So there are things like what is called in medical terms as therapeutic mammoplasties, wherein we take your breast tumor out and then shape your breast, and sometimes it might be combined with symmetrizing or a matching surgery on the other side.
Right.
Otherwise, you can always share some tissue from your local chest area,
Yes, yes.
wherein we can fill that that deformity
Correct.
or that the gap in between.
So, what Dr. Rachana is also saying, if we are having not a complete mastectomy, if it is just a breast conservation surgery or a lumpectomy, we have great number of options. If a plastic surgeon is involved immediately on table along with your tumor, not only the tumor goes, but you come out with a similar looking breast with what you had gone in. With different flap technique or mobilization technique, there are a lot which we are going to get into detail.
And I think we spend just half an hour extra beyond what a breast cancer surgeon would do.
So it's not even time consuming.
Exactly, not at all time consuming.
Right.
And overall, I feel cost wise as well, it would not be
burden at all.
Something
Yes.
that would really
Yes.
pinch your pockets.
Right.
But we can always combine those surgeries at the same time,
Yes.
and give you the right outcomes.
So I think with this, at least people have come to know that breast reconstruction 100% is possible. So there's no question.
Absolutely.
Right. Now, when I say breast reconstruction is possible, so one thing is clear, it's possible. So well and good. But when should a woman opt for a breast reconstruction? Is it at the time of cancer removal? Is it later or much later? Do one need to wait?
Okay.
So what do you think?
So it can be either time. So it could be at the same time of a cancer surgery, or you can opt to have later on as well.
Yes.
But again, a lot of factors go into it, as in you're having just a breast conservation or you're getting the whole breast removed.
Right.
and if you're having radiotherapy or not, how fit you are in
Right.
terms of, undergoing a long general anesthesia
Right.
procedure or a microvascular procedure, which take a lot of,
More time,
technical
right, right.
efforts on our and your aspect as well. And also, what are your expectations? Some procedures are quite quick and have a low downtime, whereas some are quite longer procedures and will take a a slightly longer recovery, but they'll give you lasting results as well. So
Correct.
there's no fixed answer to it. It's, I would say, it's quite tailored to the individual,
Tailored
and
to
we
the
can always
individual.
discuss
Sure.
once you're there.
So, Rachana, what I understood so far, as we are saying, we're trying to make it a little more simple for the people to understand.
Yes.
So, there is something called immediate breast reconstruction.
Yes.
That means we are doing on the same time of your primary
surgery.
cancer surgery. There's something called delayed reconstruction. That means we are doing the cancer surgery first, and much beyond later, maybe 6 months, 1 year, depending on the time frame, we'll do breast reconstruction. So we can divide it into two main groups. Now, any surgery, it cannot be told ki, it will fit every patient. That's what you're
Yes.
saying. It depends
Yes.
on the comorbidities, the health,
Yes.
the financial, the mental
Yes.
framework. Lot of things will come.
Absolutely.
But if I have to ask you, say it's a completely healthy person otherwise,
Yes.
like 45-year-old lady, and they have done a modified radical mastectomy.
Yes.
Would you suggest a immediate breast reconstruction or a delayed reconstruction? And she doesn't have, to make it a little more easy, she doesn't have distant metastasis. It's only axillary lymph nodes.
Okay.
So what do you think would be your advice for such a case?
So if she's having a mastectomy and,
Right.
hoping all our margins and everything are clear,
Right.
we need to make sure your, your
Right.
cancer margins are negative
Yes,
before we proceed
yes,
ahead with
yes.
reconstruction. So essentially there are, two types of reconstruction, if broadly categorized into implant-based reconstructions
Right.
or autologous, which is basically using your own body tissues.
Perfect.
Generally, we take tissues from your tummy or the thighs or your back sometimes, wherein we make a new breast from that
Right.
tissue. What happens is there are certain things we consider. So if you want surgery to be quick, and a quicker downtime, as we talked before, get back to work early, you can choose for an implant procedure. And it's good to do it at the same time of cancer surgeries because we already have the skin pocket.
Right.
Again, it will depend on individual cases. Sometimes some cancers need removing of extra skin, but it will vary on individual basis. So we can preserve that skin coverage on that, and you can have the implant placed.
Right.
Sometimes we combine them with something called as ADM, or which is also called as medical leather in normal terminologies, which gives that extra support to the implant. But if you were to have radiotherapy in the future, or your plan for that, I will highly suggest not to have an implant, because this is known to cause a lot of complications, like
Right.
you can have capsular contracture,
Right.
which is formation of scar
Right.
tissue around the implant,
Right.
making it very tight and not giving you a really natural result. You might have pain, it'll affect your daily activities. You can also have high chances of implant extrusion or infection, implants not working. So you'll might have to change the implants quite a few times, and
Sure.
even may not have improvement.
Sure.
In those cases, the gold standard in the UK, what we used to do was something called as autologous reconstructions, which is DF flap.
Correct.
I think most
So-
of the women
Correct.
who are childbearing, and have completed the family, do have some amount of laxity in the lower abdomen and the tummy,
right.
which means that there is good amount of tissues you can take it from there. And we can make a new breast for you in
Right.
that case. And you get a free tummy tuck at the same time. That's the advantage of that procedure.
For one, you get two results.
Exactly,
Yes,
exactly.
yes.
And they're completely long-lasting results.
Right.
So, you don't have to worry about changing them. They feel like your own breast. The
Right.
texture is so much similar.
Similar, right.
And, in the clothing, in a bra, they give you really good symmetry.
Right.
And after you complete your, finish your treatment including your nipple reconstruction and even tattooing, when you look at yourself in the mirror, you'll feel there's a breast there.
Yes, yes.
And there have been studies done which show very high satisfaction rates among women who have had autologous breast reconstruction
To implant based.
compared to an
Right,
implant-based
right.
reconstruction.
No, I hear you. See, autologous, like what you said, DIP is the one of the best.
Yes.
And you can really give a form of a breast itself. The shaping is much better.
Absolutely.
But still, in Indian kind of scenario, I see patients who are very scared for microvascular.
Agree.
This comes under a broad term of microvascular.
Absolutely.
So I don't know why they feel scared. Maybe the primary surgeon has already made them scared of it. Like my recent patient who I did a month back,
Right.
she's completely against microvascular.
Yes.
So somebody has put in her brain
Yes.
that the failure rates are much higher.
Okay.
Right? So in such scene,
Yeah.
we can do some other flaps also, right? Where we don't need a microvascular.
Actually, I would like to say something. So basically, in fact, if you are not the ideal conditions, but I would say the optimum conditions, if you're in good hands and expert care who does this procedure in and out,
Correct.
the failure rate, based on our national studies in the UK that they have done across the units, is around 3%. Whereas an implant based reconstruction in their studies is somewhere between 15 to 20%. So it's actually
the other way around, right?
Yeah, and they're in a specialized unit. So it's basically it has a low failure rate. I know that microvascular procedures will demand a lot in terms of procedure time, the recovery period. But it's like imagine like doing a big investment which is not so high risk, and it'll give you that kind of long term returns as well in the end of it.
But for that, people have to understand that it's not high risk.
Exactly.
So as rightly you're also saying, even I believe strongly, in microvascular DIP, it's all about the skill of the surgeon.
Absolutely. I think you.
The
It's a
3% is a lot of other factors come
Exactly.
in. It can be just a bad
It's a
luck.
human body.
Yes.
It's not going to be perfect.
Yes.
There are always risks and complications to any small to big
So
procedures.
it's a highly skill based surgery.
Exactly.
So
it's expert surgery. It's it has to be done in the right hands.
Right.
And only then.
Yes, then the success is beautiful. But other than that, suppose I don't want to do microvascular. This is for like a lot of patients.
Yes.
They're not in a city kind of a setup.
Yes.
If I'm doing a surgery in a smaller setup.
Yes.
If I'm doing in a village or a smaller two-tier cities where microscope is not there, I don't have a skilled surgeon. So still these women can get reconstruction done?
Yes, they can have reconstruction as well. So as we spoke about the implant based, we can do it, that is done, takes a couple of hours extra beyond your cancer surgery at the same time. Or you can do it afterwards, but that will involve putting an expander underneath your skin.
Right.
And you'll have to, come multiple times to get the expander inflated to a certain volume, and then we would place an implant, a final implant underneath.
Yes.
Versus, there is another option of using your back muscle, which is called the latissimus dorsi flap or the muscle. Which we take it from your back. It's like a big fan-shaped muscle.
Right.
And we take a bit of skin as well, which generally, the scar is hidden under your bra line. Right. And we flip it across in the front. And this,
can be
used with an implant.
Reconstruction, right?
Yeah, implant. So you can, if you got good amount of volume of fat, we can substitute for your, original volume. That should be fine. But sometimes we do have to combine it with an implant as well.
So if I have to summarize, so what we are talking, me and Rachana have been trying to put it across would be reconstruction is basically two types. Either it is an implant based, right, where we are using a silicone or a saline implant, versus something called autologous. When I say autologous, that means the patient's one's own body tissue, a muscle, a fat, skin, all these are used to reconstruct a breast. Anytime an autologous reconstruction has a superior result to an implant base. Obviously, because it is your own tissue, it feels more natural. And as already told by Rachana, it is a lifelong. It has more, it lives with you, right? So it's nothing is going to go wrong eventually. But whereas if you're going for implant, it has its own complication. But broadly, it is implant based and autologous, right?
Both
if
options.
People have to,
I think there's a right candidate for both the options. It's up to a conversation between a patient and a doctor, and let them choose what is right for them. Basically.
And don't you think most of this has to be decided or can be decided even before breast cancer surgery?
Absolutely. I think they should get consultation before planning the surgery, because if they want to have it done at the same time of the cancer surgery,
right?
I know that the cancer diagnosis itself, that conversation is itself very difficult.
Yes.
And I know, it's very difficult to process that information.
Correct. The family, it's too much.
Exactly. It's too much to take for the patient. But there's no hurry. You can wait for a few days, get that second consultation done. know, things around it in terms of your
Correct.
comprehensive care, and then you can go ahead.
So what is happening, Rachana, in what I saw recently in my own apartment, a friend's mother was diagnosed with breast cancer.
Yes.
So she went to a general surgeon, and the surgeon went ahead and told the surgery has to be done immediately, tomorrow itself.
Right.
And it is not, it is just, I think, from the, I have not examined her, but it looked like a stage 2. It's not spread. But he was trying to push her into a surgery
Okay.
without even giving her an option
Yeah.
or telling her
Yeah.
that there's something called breast reconstruction.
Absolutely.
I think we are lagging a lot in that point.
I think so.
We're jumping into things.
Yes, I completely agree. I mean, as I mentioned, the doctor's expertise can go a long way in what kind of treatment you're receiving. But I would highly suggest that, I mean, we are a developing nation and we are doing really, really well. So
Right.
we, every household has, people who are now well educated. You have good resources online that are available. I would, encourage them to have a look
Yes.
before, deciding.
You need to do your own research.
research.
You cannot
And-
blindly just
Exactly,
go ahead with one
exactly.
doctor's opinion.
Exactly.
I feel.
I mean, with due respect to all the doctors,
Yes.
I think it's good to have a little idea, doing your own research, finding out what are the options that are available now, and then
Definitely, Rajat,
going
no
with
insult to a doctor. See, in my own
Absolutely.
practice, when a patient comes to me,
Yes.
many a times I tell them, please go take a second opinion.
Yes.
The things which I don't do now anymore. Like, I don't do microvascular.
Agree.
I don't do nerve surgery. I don't.
Yes.
I refer them.
Yes.
Because I know I'm not the best person for that.
And what we all are aiming for is better outcome and
Yes.
something that, satisfies that
The
patient.
best for the patient.
Exactly.
It's not
we
about
are all
ego.
patient
Yes.
oriented, patient centric. So we are thinking in terms of your best care.
Best, yes.
Exactly. So you're absolutely right, Pinky. So
We can. They have to have a idea before getting into
Yes.
primary surgery for the cancer itself,
Yes,
isn't
and
it?
it's a growing specialty, but and we need to make sure that it reaches the masses, and
Right.
I think it's quite up to us as well to kind of see
Right.
how far we can create that awareness.
I think as we were talking, we somehow got diverted. So I think we started this talk with the thing was
Yeah.
whether you prefer immediate reconstruction versus delayed.
Oh yeah, I'm so sorry.
Yeah, the question
I missed
was
the point.
that.
I got carried away,
Yes.
possibly.
So what is in your opinion,
yes.
if you can
So-
say the pros and cons for each?
Yeah, I think, results wise, if you say, and immediate will be maybe slightly better. I wouldn't say it's quite significantly,
Okay.
because if you lack the skin, so if you have an MRM, you likely have a long scar
Right.
and a missing skin of the breast
Right.
tissue envelope that you
Right.
would usually have. If I'm doing an autologous reconstruction, I can always share that skin from your tummy. So I can
Right.
make that breast fold again for
Right.
you. That's not a problem. It will just be a difference of the skin patterns
Right.
that you might have. For implant, I would, for the implants, obviously your skin will need expanding further, which
Correct.
means you might have to have stage procedures. And then in between, you'll have some hospital appointments to visit a doctor for inflation and things. So there is no, I wouldn't say one is right, another is wrong. It's, again, I would go entirely by how that patient is. Is the patient ready or not? That's very important for that
So
procedure.
you're saying technique wise, result wise, immediate versus delayed doesn't make too much of a difference.
But,
There is, but not
my
significant.
preference, if it was me, I would probably opt for an immediate one because I'm having the cancer surgery
Yes.
anyway. So, my insurance might cover it at the same time, which is important. And I can get it might be an extended surgery, a longer recovery, but everything is done and dusted. If I was to have a radiotherapy in future, I've had autologous and I'm happy, I can still have
Yes.
radiotherapy over my autologous reconstruction.
And even I think it has quite a bit positive psychological impact.
Absolutely.
You're never
Absolutely.
breastless.
You're very right.
Yeah,
So-
when you come out of the theater,
Exactly. You're going
you
in
come
with the
back.
breast.
Yeah, you come back
out
with the
with a
breast.
new breast.
So I think it's very important psychologically, the
Absolutely.
mental well-being of
Yes.
the woman.
Yes.
But many a times, as you already said, since the result wise is not significant difference,
Yes.
some cases is better to delay. Like if we don't
Yeah.
have we are not sure
Yeah.
of the cancer clearance.
Yes.
We cannot jump into a reconstruction.
Exactly. Like some patients may be complicated. We don't know if they are extending beyond on a chest wall,
Yes.
or if your armpit is clear or not. Or if you're not in a general health, if you have diabetes or
Yes.
something and their sugars are very high,
Yes.
which can impact our wound healing. And
might as well
kind
delay in that.
exactly. It might, or you're on some steroids for some
Right.
other, rheumatological reasons or something. It may not be the right choice to undergo such a, an extensive procedure. So
Because
it
I
might
think in any cancer for the matter of fact,
Yeah.
the cancer clearance importance is more important than your reconstruction. I
Absolutely.
think that's what we all agree. All
Absolutely.
reconstructive surgeons.
Absolutely.
The basic is first, the cancer has to be clear. Like
Yeah.
we like to say, life comes before
Yes.
part,
Yes.
right? So the
yes.
life of the patient is the most important.
So your cancer clearance is the most important on that day of surgery.
Yes.
Reconstruction, I agree, takes a back seat. It can
Right.
happen same time or later.
Yes.
But that is the most important. We
So the
want you
woman-
to recover afterwards.
The woman need not get disheartened, right? If they are not done immediate, it doesn't mean they can't do it.
No. It's
They
not the
can
end of the world
It's
at
not
all.
the end, yes.
You still have the option. Once if you finish radiotherapy, normally we ask you to wait for around 6 months before
Right.
we go ahead with
the
further
reconstruction.
reconstruction.
So it is possible.
Yes.
Now, there's something like, we say preventive or a prophylactic mastectomy.
Yeah. Yeah.
So when is it done? What kind of woman we are doing that?
An excellent point made there, Pinky. So I think we still lack a lot of awareness in terms of prophylactic mastectomies. We all have heard about Angelina Jolie.
Yes, that's
who's
only
had,
exactly. Thankfully, she came out forward with it, and that's why a lot of people have heard the term.
So what I would suggest, the women, not women, but even men for that matter, if you know about a gene called a BRCA gene, BRCA1 or 2,
Right.
and there are still more evolving genes. So there's a lot of research going on. They're finding more and more genes like PLAB2 gene, CHEK2 gene. These are all high risk genes which give you a certain, make you high risk to develop a breast or even an ovarian cancer.
Right.
And it is quite a multidisciplinary inputs that we need in that case. So it is good to consult even an oncologist who can risk assess you. So they will have certain tools and they'll tell you what is the percentage
Of
risk
risk you carry, yes.
that you have a percentage risk of developing a breast cancer in the future. And when I was in the UK, we used to have a lot of young women, even in their 20s. So they would have their mothers or their grandmothers in their 40s and 30s developing breast cancer. So obviously there was a lot of anxiety around it, that risk of developing breast cancer in the future. So we would offer them prophylactic mastectomy. So basically, you excise all the breast tissue before you develop the cancer
Even before
into
the
it.
cancer develops, yes.
And obviously we would offer them reconstruction at the same time, because it's going to be a lot of psychological impact on these ladies, because they are normally healthy.
And they went with a normal breast, right? They don't have cancer. So prophylaxis means the cancer is still not come.
Exactly.
So we are doing before that.
Yes. And obviously it will, the survival rates are it's going to impact a lot on your future morbidity, survival, and things like that. I also want to stress that obviously if you know about that gene in your family, it makes things easier. But we would also have women who have that family history, a very strong family history of breast cancer running in their mothers and their sisters.
The woman is the family, basically the aunt.
But they would undergo a genetic testing. However, the genes would come out to be negative.
Okay.
So those kind of patients, we would individually assess the risk. And if there was certain cutoff, say about 25 or 30% risk of developing breast cancer, then those women would also be offered, prophylactic mastectomies in those cases, because it's an ongoing research. We still don't know so many genes which are causing breast cancer, and it's also good to know that these genes travel via men as well. So, you have to trace it either side, and men also are at equal risk of developing breast cancers.
This is a very good point you made, because all of us, non-medical people, until us, we are dealing with cancer.
Yes.
We feel breast cancer is only for female. Yes. Or it has to come from your mother or grand. So you're saying
men are not spared.
Yeah, men are not spared. Yes, because men have breast tissue. It's not like,
So I think the incidence is somewhere like 99:1.
Yeah, but they still can have it.
Still there.
So what you're saying is, if breast cancer is a genetically predisposed in such family, and hence we are giving prophylactic.
Yes.
So the way a person can know whether they're predisposed or not, having a history in the family.
Yes.
Somebody, mother or maternal family or paternal also.
Absolutely. And it could be anything like even ovarian cancers. Some cancers go along with each other. So breast cancer, ovarian cancer, their mother, grandmother, on both paternal and maternal side, and sisters or even cousins for that matter. So if it's via father.
So it's not only breast. They could have a history of ovary, and this particular person whom we are talking can be prone for breast.
Yes.
So once you do the risk assessment, we have tools for that.
Absolutely.
We can do the genetic mapping and all that, find out the gene. And if it is, then it's better to go for a prophylactic mastectomy.
Yes.
right?
Yes. Absolutely.
But the controversial topic here,
Yeah.
Rachana, is
Yes.
when we do prophylactic mastectomy, we can't remove 100%.
Yeah.
Some breast tissue,
Yes.
maybe 5%,
Yes.
10%.
Yes.
Because we are
Yes.
leaving
You're
the
right.
skin behind,
You're right.
right? We
You're
never
right.
remove the skin in a prophylactic.
Absolutely.
Either we are doing nipple areola sparing, even sparing that we
Yes,
do.
we are doing that as well.
Yeah. So still they have that risk.
But that risk is quite similar if you were to have, a skin sparing mastectomy in a cancer patient. So they say there's a, if you do a complete MRM, there is still a small amount of tissue
Exactly.
that's left behind. If you
Correct.
leave the skin behind, it might be 2 to 3% extra. And if you leave the nipple behind, they say it is 1.5% extra. So overall, it's not a kind of a strong impact onto that recurrence rate, and it is still quite an acceptable amount of risk that you're carrying. And obviously you would be asked to examine yourself afterwards to undergo
They
some
need to
imaging.
go for the assessment. Yeah,
Absolutely.
right.
Absolutely.
So what I think as doctors we know very well, because all my patients for anything they come, doctor give me 100% surety. There's nothing called 100%.
Absolutely not.
Right?
No.
Whatever the best of the doctors, the best
Yes.
of the imaging, the best of the hospital
Yes.
setup.
Yes.
We can never say you're 100% zero risk.
Exactly. Even
right?
if I were to remove all the breast tissue, you
Exactly.
still have some amount of
Yes.
cells which are quite microscopic, and it's physically not possible to get everything out.
So you may be that 1 in billions
Exactly.
who still can develop.
Absolutely.
So we only thing is we are reducing the risk drastically.
Yeah.
Without the surgery, say for example, I'm giving
Yeah.
you not a scientific number, you are
So
50% chance, but this will
exactly.
reduce to
So
1%.
when you're doing a prophylactic mastectomy, you're reducing the risk at least by 90%, possibly 95%. But it's still you're having a large advantage of
Correct.
somebody who would not have a mastectomy.
So if I have to explain to a normal way, when we say 95% reduction,
Yes.
doesn't that mean out of the 100 women, 95% women will not get it?
I think so.
You
Yeah,
know?
you're
So
absolutely
no,
right.
for people
So
to understand that, what
exactly.
is 95?
Yes.
So out of the 100, that
Yes.
5 people
Yes.
may develop,
Yes.
right? But that's
May
a
develop,
huge
but yeah.
reduction, right?
It's a big reduction. So
So prophylactic mastectomy in high risk
yes, is highly advised.
right?
Exactly.
So I think they do even ovarian oophorectomy. They do it
So
along
we
with it.
often, when we used to do these BRCA patients in the UK, we would do prophylactic mastectomies, reconstruction using generally from tummy tissues, and at the same time we would have our gynecologist colleague
Who will
coming
do it in the same,
through the
yes,
same
open up,
same
yes.
open abdomen.
Yes.
It would just take 10-15 minutes extra for them to get the ovaries out,
And
which means
the patient goes out peacefully.
Yes,
Right?
absolutely.
That's a less risk.
Yes. There are some questions I know that they women who are of childbearing age
Right.
or planning for family in future, they are always concerned as to if they were to have oophorectomies, what would happen. So there are options of preserving your eggs as well now. So if you were to choose to preserve your eggs and then have your surgeries, and then later on you can have assisted reproduction techniques.
Wow.
Wherein you can.
So science has really made progress, isn't it?
Yes, absolutely. But also there is, some women do not want to pass that genes on to their children as well.
Yes.
So in the UK we did have some techniques wherein you can, differentiate those genes and, just basically separate out those eggs.
So basically you can give all the option to the
Exactly.
woman, right?
She
can take
completely
a call.
decide. She can take a
It's
donor
educated
ovum if needed.
decision.
Exactly.
It's not like
no.
blind.
So, yes,
It's
absolutely.
not
Everything is informed
yes.
entirely up to the patient itself.
What they would like to do.
Exactly. We'll give you all the options though.
Now, breast reconstruction. So we understood from our talk that breast reconstruction is a possibility. One.
Yes.
Because a lot of people don't know it's a possibility. Definitely possible. Definitely can be done immediate or later.
Absolutely.
Depending on the scenario. And it is easily available. There's no dearth of qualified doctors.
It's quite, right? Yeah.
There are quite good number of people who are really trained.
Yes.
You just need to go to the right
person.
Doctor.
Yes.
And then things would be sorted. Now, this is about breast. A lot of even this patient of mine whom I was talking. So left side I did reconstruction.
Yeah.
But obviously when we do reconstruction, we cannot give the size of the opposite side. If it is one side breast cancer.
Yes.
So don't you think it's always better to, on the normal side also, to give a better cosmetic result?
Yes.
Either go for a breast lift or breast reduction depending on the scene. What is your take on that?
So definitely, every woman is different. Every breast shape is different.
right.
Contour is different. Volume is different. And the amount of tissue we can make readily available. Some women have good donor amount of tissue and small breast, and vice versa. So those are the challenges we have to face as a doctor. And we may not be sometimes able to get enough amount of tissue
Right,
if it is not
exactly.
available.
Correct.
And we might have to go a little smaller, but appropriate to your essentially your
Correct.
body frame.
Correct.
And in fact, some women are happy to go smaller as well because they're really
yes.
tired with
They're tired
heavy
of the heavy
breasts.
breast, yes.
So in those cases, we definitely at the same time or even delayed. Again, individually,
Yes.
we can decide that, but we can plan a symmetrizing surgery. Quite often, what we
I
call.
think it's a very important part. It's
Exactly.
not, see, I think we have moved away by just putting some tissue there.
Yeah.
Breast reconstruction is not about just covering that area.
Yeah.
It is also giving a aesthetic breast.
Exactly.
Which looks like breast, feels like breast.
Yes.
Psychological effect
Yes.
also. So I strongly believe if needed, the normal side breast should also be corrected depending on the scene,
Yes.
whether it's reduction, left or impact.
Yes.
Now, having said this, we have constructed the breast. But can the nipple and areola also be reconstructed? Because that's a big part of your breast.
Yes. So that is what we call the cherry on the top commonly.
Right.
So we
But that's the
normally
most important thing.
to make it look like, imagine,
Yes.
having a face without a nose,
Yes.
something like that.
Right.
So we would do it at the end of our procedures in the UK when I was a part of that breast unit. So once, if that patient or the woman is happy with both the size, shape,
Yes.
symmetry, and once she's, at a plateau, because what happens when we reconstructed your breast, they look a bit more perkier and sitting slightly high up.
Yes.
And slowly with healing over a year or 2 years, they will drop down and sit
they
at their
settle to
natural,
the- yes,
natural
yes.
place. So we prefer not to make a nipple for you at the same time. We want to make sure when we do it, it's at the exact level where it is going to be for a long, long time.
Right.
So yes, we can definitely, what we do, there are different types of nipple reconstruction you can have. One is using that same tissue, what we call a local flap.
Right.
So we do something called a skin origami. So we
Correct.
take that skin from there and then we make it shape look like a nipple projection.
Right.
And then we can always have tattooing. So
Right.
if some women may not like a nipple which is always sticking out, in that case, they can have a 3D tattoo or something by an expert. And then you can have for the areola, the darker area of skin around your nipple can be done tattooing as well. Or sometimes you can skin graft it as well, which can give you a little more, like a darker a texture to it to look like that.
So it is definitely possible.
Absolutely.
So I think at the end of a proper breast reconstruction,
Yes.
done by a
And
proper
it's
expert.
a very like a 15-minute procedure. Can be done under local anesthesia, in and out. It's nowhere close to what you had that big procedures for reconstruction.
You don't have to fear, but such
Absolutely.
small things, out of time patient is so hesitant.
Yes.
Because the experience of long surgeries.
Yes.
But without that, it's not complete.
No. And as I mentioned, Pinky, so basically there was some research done. They had satisfaction rates of women looking at the mirror with nipple on versus not a nipple on. So they never felt that was their normal breast till you have that face, that nose to the face.
It just looked like something been put
Exactly.
there.
Exactly.
That's why I was saying it's breast reconstruction is not about putting
Just the
some
breast.
tissue there.
Exactly.
We need to give the form. We need to give the contour. So nipple and areola is the one of the very important part of it.
So,
but as rightly told by you, it is done at the end of the procedure. We need to wait.
Absolutely.
We cannot hurry. So it is definitely it needs multiple stages.
Absolutely, I agree. If you want, for the better outcomes, I would say for stage procedures rather than going everything at the same time.
Because I see a lot of women are in a hurry.
Yeah.
Doctor, do everything today itself.
No.
In one go.
I think,
so I said no.
Yeah.
You need to wait.
Because you're healing, if you're planning to have some cancer treatments ahead, they go overall, impact a lot on your healing tissues as well and how your breast essentially is going to be, over a period of time. So yes.
Yes, we need to wait.
Absolutely need to wait.
So Rachana, I think we have spoken quite extensively about breast cancer, cancer reconstruction, delayed, immediate and all that. But I think a major factor in India especially, it's the finance.
Yes.
Right? Because in India, still people think it's a cosmetic procedure. The moment the thought process changes, if they feel it's a necessity, then cost wouldn't matter much.
Agree.
But since the thing is a cosmetic, and somehow women, given less importance than most of the families. She's just there to take care of everything.
Yeah.
How costly is this reconstruction?
Okay, I think first of all I would like to highlight it's just not a cosmetic thing. It can have both
Correct.
physical and psychological
Yes.
effects on that lady. So you can have asymmetry, you can have spine issues, posture issues with one
Exactly.
side of the breast missing, and obviously psychological impact in terms of their social life and
Right.
overall. So in terms, I would want to make those women aware that they need to look after self. Be aware of that body image that is there, and try to basically listen to your own body essentially. In terms of finance options, as I'm getting to know, so there are good insurances which will help you cover these breast cancer and the reconstruction surgeries as well.
But I don't know how far it is true in India, because whatever I have heard,
Yes.
if I'm doing a reconstruction along with cancer surgery,
Yes.
same day,
Yes.
same OT, it covers.
Right.
But if it is a delayed reconstruction, it doesn't cover under insurance.
Yeah, that's what I mean. Obviously, I'm just starting my practice in India, so I'm getting to know those things. So immediate will be covered easily.
Yes.
If you have a good insurance.
Delayed, they're saying they take it as a cosmetic procedure,
Right.
which is totally
Which
wrong.
is actually, I feel, because that lady is already suffering.
Yes.
With posture issues and things. So I'm not sure. I mean, how
I know, because of it has to be non-cosmetic. Period.
Absolutely.
But insurance people are.
And it's still a process of your extended cancer surgery.
Yes.
It is not a cosmetic surgery as such, isn't
But
it?
till we reach that point, there are a lot of things when it comes to
Agreed.
insurance. That's not in the doctor's hand at all.
Absolutely.
I always tell my patient, I cannot do anything about the insurance.
Yeah.
They can reject for any silly reason.
Yes.
Right?
Yes.
And it all depends what kind of premium you're paying, what kind of insurance company you have taken. But apart from that, suppose a person doesn't have insurance.
Yeah.
If you have an idea, say, if I'm going for a breast implant reconstruction versus autologous reconstruction,
Yeah.
what is the cost difference? Is one more expensive than the other?
So I think compared to implant reconstructions, autologous reconstruction, especially if it was to microvascular, will be definitely a bit more expensive.
Yes.
Simply because the procedure is extensive, involves
Right.
a lot of surgical areas and
I think
rehabilitation
just for the
afterwards
factor
as
that
well.
OT time is more.
OT time is more, the consumables we use are
Is
slightly more,
Right.
expensive. Your extended stay in the hospital would contribute as well. And there's a little bit of rehabilitation which goes as well. So it will be slightly more expensive, but as I mentioned, it's like you're investing into a, something which might last you
Right.
forever.
That's what we want to point out here.
Yeah.
One time you may feel it's expensive,
Exactly.
but in the long run,
In the long run, if you were to have an implant and you might have to change it, suppose every 7 years or 2 years or 20 years, we don't know, you might end up spending possibly more for your implant, maintaining those implants, in the next 20 years.
so autologous definitely in the long run will turn out at least not cheaper, at least equal.
Equal, if
Right?
not cheaper, definitely.
So, but again, here other point I would like to make here is this reconstruction. The cost will depend on the setup,
Yeah.
kind of hospital,
Yes.
what level of hospital,
Yes.
and the qualification of the doctor, how
Yes.
trained the doctor is.
Yes.
Hospital, because the bigger the hospital, the more.
Yeah.
Now, since I am running my own center, I know.
Yes.
Bigger the hospital, there's a lot of expenses, so you cannot blame them for why the cost.
Yeah.
But one thing I want to make a point here is don't compromise on the skill of the doctor.
Yeah. No. Yes.
And don't think, okay, some doctors doing for cheap.
Yeah.
I will go there.
Yeah.
But he may mess up the only chance.
Exactly.
Like DIP.
Exactly. You just have one chance at DIP.
Yes.
It's important to know that there's no second chance.
There's
like
no second
implant,
chance.
you can have second, but your DIP flap you can possibly
It's only
have
one,
only
right?
once. Exactly.
So might as well get it done from the best.
Yeah.
Rather than compromising because of little bit of
Exactly.
finance.
Because that's they only have one chance, as Pinky said, and you make sure you go to the right person with the right expertise. And with the centers, I would say with microvascular surgery, there's a little. What happens is because it's a extensive procedure involving the anesthetist is equally important, the physiotherapist is important, monitoring team is important.
Yes.
So it's good to have that kind of backup in such kind of
So
hospital.
it's a teamwork. It's
a
not
teamwork.
one surgeon,
It's just not
right?
one surgeon
Yeah.
at all. It
So
goes.
obviously
It
it
makes
comes with
sense
the
to go
cost.
to the right place for
Yes.
that, which is known to handle such kind of cases very well.
So expense will be there. So if you're really interested in getting a breast reconstruction, say it is a DIP flap, kindly don't compromise just because of the finances. Money matters definitely, but if you're bothered to have a breast, might as well get from the best and don't lose that chance. So this is a very important point which I even face in my day-to-day practice. When you try to compromise a lot on money, you go to the wrong hands and you really mess up. So let's not do that. Having said that, Rachana, now finances we discuss. But if you have to say, how can a woman
Yeah.
self-diagnose?
Yes.
This is a very important thing, but a lot of women are not aware.
Yes.
Self-assessment,
Yes.
and are there any tests? How often they need to get it done? Can you just highlight a bit on that?
So, very importantly, we all have heard about self-examination
Yes.
of the breast,
Yes.
that, be it of any age group, you need to examine your breast at least once or twice a month. Ideally, they say before, 5 to 7 days after you finish your periods, when your breasts are slightly more lighter.
Right.
And then you examine all the four quadrants around it in different positions, keeping your arms up on the sides, sleeping position and standing position as well, and feel for any, and your breasts well, basically.
Yes.
So you know the texture of your breast, which could be different from every lady
yes.
to lady.
Yes.
So any changes, you would be easily able to pick it up. And also look for any skin changes, any nipple discharge that you have,
Right.
which can be sometimes be
Yes.
a harbinger of a cancer as well. So those kind of changes you look for on a microscopic level, I would say. And then consult your doctor, obviously, if you have any questions or concerns.
Don't hesitate.
Don't
You find
hesitate
little
at
bit
all.
of
Even
normal,
little
yes.
changes, because earlier the better.
Yes.
If we detect cancers at an early stage, it is curative.
Right. That's
So that is the whole point. And obviously it's screening. So screening mammograms and ultrasounds that can be done starting age 40. Every 1 or 2 years you can repeat them, because a lot of these lesions cannot be palpated. You may not be
Yes.
able to feel it.
Yes.
And they may be picked up on certain scans.
So you see, after 40 is better. Every at least 3 years.
2 years is the
2 years you
guidelines usually
go for a
after 40,
mammogram.
after mammogram.
Yes.
And also I want to highlight that if you have family history of breast cancer, as we
Yes.
spoke about the BRCA genes, the tendency was you would need screening at an earlier age, so possibly starting even in your 20s sometimes.
Right.
And there are things like MRI and all which will pick up these lesions better, because you'll have certain more dense breasts when you're younger.
Yes.
So a mammogram may not be enough.
MRI may be needed.
You might have to complement it with the MRI as well.
Yes. So isn't it like, if you have a family history, suppose your relative, mother, whoever, got a cancer at say 30.
Yes.
So you start screening at least 5 years before that? Is there a timeline like that?
So there is no timeline as such. Normally, if a lady was in her 20s, for example, and she knows that there is certain history in the family, and she has that high percentage risk,
Right.
and she fits into that criteria, she can start screening right away. It doesn't have to be a certain
You need not
age
wait.
at all. Exactly.
You don't have to wait, okay,
Exactly.
after 30 I will start.
No, it is nothing like that. The
The
earlier
moment
the
a breast
better.
develops.
Absolutely.
Something
Earlier the
like that.
better. And I think there is high incidence of smoking in women now.
Yes.
Obesity is rising, which are all predisposing risk factors for breast cancer.
Right.
So, the earlier the better.
Always.
Earlier the better.
So today I think we had a very meaningful discussion with Dr. Rachana, who helped us understand about breast cancer and its reconstruction. The takeaway message always is breast reconstruction is not a cosmetic procedure, and it is definitely possible in every lady. Maybe immediate, delayed, doesn't matter. Please explore your option. Don't think it is okay to be without breasts. No, it has a huge impact on a woman, and the family member, the society need to support this. So, signing off with this last take home message, I would really like to thank Rachana for being here and really having a, enlightening kind of a
Thank you
discussion.
for inviting me here, Pinky. It's been really a pleasure discussing all, the options of breast reconstruction
For
with
women,
you.
right? We have to.
Absolutely. I know. We are
Yes.
pro women and
Pro-women,
women's health.
yes.
Absolutely. Absolutely.
Thank you so much.
Thank you.